place. How weird. Hello, welcome. We've had our first glitch. That was marvelous. Yes, welcome to this session on the challenge, ironically, of effective communication with VTE patients. We've got a group of people, as has already been said by Joe. We've got a patient representative, we've got some nurses and a clinician, a physician. And the plan of the day is that each of those people will talk for 5 minutes from their perspective about the challenge of effective communication. And then there will be, Sinead's looking and thinking, did I offer through this? And then there will be a combined discussion. So I shall be frantically taking notes about common issues. But if people, if there are issues that people that are watching would like to comment on or ask or talk about, then if you can use the Q&A or the chat function, I will be monitoring that, and I will address those so that I can bring them to the attention of people. A lot of feedback on Paul's audio. Does that mean, can people hear me now? Are there any problems? I'm not quite sure what the original glitch was because I wasn't. Joe says it's okay, fine. Okay, so without further ado, because we're taking up time now, I'd like to introduce the first member of the panel, and that is Hannah Eden. So come in, Hannah, your time is up. Come from behind the door. And Hannah, just a little bit about Hannah. She was diagnosed with a deep vein thrombosis, a DVT, around 3 years ago, and has had issues, I think, in communication in terms of the initial diagnosis and subsequently. She has an interest as a result of that, I guess, in the psychological impact of VTE. And she's not quite the naive clinician, patient that we might think, because she actually is a trainee midwife. So I'll hand you over to Hannah, who will have her 5 minutes.
That's great, thank you, Paul. Yeah, so as Paul said, my name's Hannah. I'm 22 years old and I had my deep vein thrombosis when I was 18. It was in May 2019. Prior to this, I knew about blood clots. I knew what they were. I knew they could happen, but I was very much under the impression that they could only happen really to older people or people that had risk factors like a long-term flight or something like that. So yeah, I had when I started to have symptoms of a DVT, I went to visit my GP, and the first sort of communication I had regarding my symptoms was poor from the offset. I didn't have a good experience with communicating with my doctor. She was quite dismissive of my symptoms. She just did the routine blood tests, which came back supposedly normal. From there, my symptoms just carried on over the space of 2 weeks. My symptoms were just getting worse, but slowly. So I was put on to anti-inflammatories. I was told it could be arthritis. So then at that point, I was looking at myself, at my symptoms. I was looking at how I was feeling. So I was having heat around my knee joint, and the swelling had all started just around my knee. And then the swelling had started to spread down, sort of into my calf and upwards as well. So I started to look myself at how my symptoms were developing and what it could mean for me. I did a bit of a Dr. Google, which isn't always safe. I then visited a local A&E unit. So I was really concerned about my symptoms and how I was feeling, and all the different medications I've been given weren't working. I went to an A&E unit where, of course, we have horrendous wait times normally. So I sat waiting for a really long time. I think I was there about 6 hours. Before I was even seen by somebody, and they were confused. The clinician that I saw just seemed confused. She said, "These are actually symptoms of a blood clot, you're right, but you're too young." And that's the first time I was told I'm too young to have a blood clot. And this was then like a recurring theme. You know, you're 18 years old, it won't be that, you've got no risk factors, you're not on the pill, you've not been on a flight, all of these things. So yeah, this communication journey that I've been on with this range of clinicians only up until this point had not been a good experience for me. I didn't feel listened to. And that was the most frustrating bit. I didn't feel like I was being supported in how I was feeling. So I had some blood tests and I was sent away. I was told to come back the following day for an ultrasound scan. I went for the scan and was told there was nothing there. So again, felt really deflated. They made me feel a bit stupid in a way, like, you've been told not to worry, why are you still worrying? They were all confused. They didn't know why I had these symptoms, but they were adamant it wasn't a blood clot. Anyway, fast forward a week, I went to a different A&E unit, sat for a long time again, except I had a much more positive experience. I was really listened to. The nurses and the doctors really advocated for how I was feeling and really pressed for me to get some answers. So I had another ultrasound scan, and immediately they picked up a DVT in my left leg. So this journey of 3 weeks, I finally felt listened to. I felt like somebody had understood that my symptoms weren't normal and that something wasn't okay. So yeah, that was kind of my journey up to that point with the communication. I finally got listened to. I was then referred to a haematologist at that trust. And again, this haematologist was fantastic. I felt really lucky. I felt really supported. I was referred immediately for loads of different scans. I had a CT scan, an MRI scan, and a couple of other types of scans. And at that point, they were looking for a cause of the blood clot. They found that even though I had no risk factors, they believe it's because I was born prematurely. I was born at 26 weeks, and they think it's to do with a development problem with my blood vessels. So I'm now on anticoagulation for life. But then since my diagnosis, the communication got better. So my haematologist was really supportive. I saw radiologists, I saw vascular surgeons, and I felt as though after the problem had been identified, the communication was better for me. And going back to what Paul mentioned about the psychological aspect, I think that's probably one area of communication since my diagnosis that needs to be improved on. I think health professionals aren't always aware of the psychological impact of VTE on a patient. And yeah, I think communication around that area needs to be strengthened, which I think could make a big difference to patients moving forwards. So yeah, I think that's me, Paul. Thank you.
I'm here. Can you hear me now? I'm slightly worried now. My microphone isn't working.
I can hear you fine, Paul.
Oh, thank the Lord for that. Thanks, Hannah. That's really interesting, and I've certainly got some points that I want to raise as we go through it, or questions I want to ask as a result of that. So thank you for that 5 minutes, keeping to time beautifully.
No problem.
Next person to talk, if she's just arrived now, is Jackie Merchant. So Jackie, can you come from behind the door and make yourself visible, please? Oh, there you are. You've moved on my thing, and excellent. So one of the things I've discovered today is that there is only one St. Peter's Hospital in England, I think, because I looked at where you're working and it came up. So Jackie is an anticoagulation nurse. She's got a history of working in various things in nursing, but in 2004, she started working part-time in the anticoagulation department. And since then, she's moved to be a full-time anticoagulation nurse specialist. And she helps people manage their anticoagulation therapy, provide support, and so forth. So I'll hand over to Jackie for her 5 minutes about communication.
Hello, everyone. So yeah, I work in quite a small unit. We do lots of things within our unit. We look after around 1,000 patients who are on warfarin. We support other doctors and healthcare professionals within the trust. We also provide perioperative plans so that we can give more information to the patient, etc. And ongoing warfarin management, and basically providing anticoagulation counselling for patients. So we are not in the A&E department. We rely on A&E department to send patients with us. And basically, I've looked at communication as I see it, and the most important part of communication. And funnily enough, I didn't actually hear all of what Hannah could say, but I did hear that for a lot of the time nobody listened to her. She was saying things and nobody was really listening to her, which is really funny. I kind of looked at all the challenges that we do when we do counselling with patients, and the one thing that I thought I would focus on is actually how we tailor information to the patient and give them the ability to understand. So any patient who's diagnosed with thrombosis needs to be given that advice regarding their treatment and the benefits of treatment. They need to know things like how the medication works, the importance of taking their medications, what to do if, depending on what kind of medication they're on, what complications can arise, etc. And they need to know when to stop their medication. But one of the things I find when counselling patients at this stage is they're still in a state of shock. They've been diagnosed with a thrombotic episode, and before now it didn't mean anything to them. And their capacity to actually take on board the information is quite difficult because they're in a new phase in their life. They haven't exactly moved on from being told they've had a DVT and it's going to affect them. And usually the information they get by the time they get to us is quite sporadic. And you do hear patients saying, I was told by a doctor that if I'd left it another day, I would have died. So you have a patient within this state of mind. And what you need to do, mainly when you're counselling a patient, you have to give this information to the patient because every patient needs this information. But you have to adjust your list depending on the patient's individual abilities, concerns and understanding of what you're saying to them. Some patients require a lot more information, whereas others require a lot less. But the way you can adjust the information you give to patients is by listening to them. I always give the patients a good opportunity to pose questions, to ask questions that they need to ask, even if they think they're stupid, because they do need answers. These questions will always be there in that patient's mind. And unless you can answer those questions for them, they're never going to get over that moment. So really, when I look at the most important thing of communication with a patient is actually your ability to find from the patient what they need to know to be able to arm the patient and give them the opportunity going forward to take ownership of their care or actually be part of their care and their treatment, and give them a way forward how to cope with the situation and everything else that goes with it. And it also helps you to learn a lot more from the patient themselves, so you can improve what needs to be done within your service, and you can review and reflect on what has happened with individual patients, and then you can improve your service, make it a more patient-friendly service going forward. So that's about.
Brilliant, thank you, Jackie. That was amazing. Lots of issues there, but no, as a psychologist, I thoroughly approve. That sounds cracking. But we'll move on. There's points I've raised, and maybe other people will raise in the questions. Don't forget, we've got the Q&A that can raise some issues if people have particular questions triggered by these various talks and little vignettes that people are giving. So thank you, Jackie, and we'll move to Sinead, who's yes, I'm enjoying a little comment made here. Sinead, who's got her 5 minutes of talking, and Sinead is another clinical nurse specialist working at King's Hospital, and she's been working in thrombosis and hemostasis for 8 years, since 2014. So a lot of expertise. So hand you over to Sinead.
Thank you very much. Hopefully you can hear me. That's the sort of question of the day, really. And thank you to Jackie, who's probably got a very similar experience to myself, actually, sort of working in a similar service, except that perhaps we are sort of serving a larger population perhaps as well. And to Hannah as well. So hopefully some of the things that she said I had actually made notes on, and I promise I had already, but they're the sort of things that we all would want to explore a little bit further as well. I'm involved in looking after patients potentially at diagnosis too, so that diagnosis relies on a referral from perhaps the community, so a GP, or perhaps a patient that's been seen in A&E out of hours, or another area out of hours as well. So we are the ones that should have our ears open and listen to, and hopefully we're in a very good position to be listening out for any alarming symptoms. I suppose for our patients, they need to get through other services first. And I think awareness of VTE has definitely improved over the years, but there's definitely still a long way to go. And I think Hannah herself sharing that experience just sort of validates that this still occurs, that certain clinicians, VTE still isn't on their radar necessarily, especially in those populations that don't quite fit the criteria of a VTE patient as well. And we've still got work to do around education of that as well. In terms of the listening to, it really creates problems further down the line for patients as well. So patients that have had a delay in diagnosis then go on, and their symptoms then sometimes progress and things get worse. They become, if it's a PE, they become more breathless, or leg swelling or symptoms. The clot has extended during the time that they're trying to sort of fight for diagnosis as well. And then that makes the whole experience far more scary. And of course, on top of that, frustrating as well. So it can be difficult for us as clinicians to rectify that sometimes for patients, especially when then you confirm the diagnosis as well. So I think being sensitive to that, if the, how their sort of diagnosis has come about, and acknowledging that, we definitely, again, from Hannah sort of sharing her experience, have got the opportunity to make things better if patients haven't always had the best experience in the first place. So once they have been diagnosed and they're seeing us, we can share our expertise and acknowledgement that, this isn't the norm for these patients, especially if it's your first diagnosis, you're young, it's potentially life-changing to you at that point as well. So acknowledging that that's the case can really go a long way for patients as well. I think the challenge we have sometimes, Jackie will probably also be able to say yes to this, is the amount of time we get to spend with patients at when they are diagnosed. So we sort of have about 45 minutes to an hour, which is actually quite a long appointment really in the NHS. And we're lucky enough to have that appointment, but often we're left feeling like we'd perhaps want even more time with patients at first diagnosis. Often there are lots of questions, often there's not, because they're in shock, but equally we need to get the correct information in so it could be safe for patients to then, we're going to discharge those patients off as well. A way we sort of tackle that is by usually trying to follow up at a week, so acknowledging that they're probably not going to take all that information in at the first consultation, and that we need to follow up just to make sure patients are okay fairly soon after their diagnosis and things are going well. Again, if they haven't had the best experience at diagnosis, things like that consultation can really go a long way in helping patients sort of recover from all of that. The other thing is sort of, again, and this is something, we've been doing the same old thing for a long time in my service, and it works well when it does work. But what we have sort of acknowledged probably in the last sort of year to 18 months is that we need to incorporate some sort of mental health or wellbeing assessment in our consultation. I suppose the question, and perhaps we'll explore this today, is when is the best time to do that? Probably not straight at diagnosis, so asking patients sort of, you know, are they anxious at that point is particularly helpful, but thinking about when we should differentiate between being sort of anxious about what's just happened to them and then prolonged levels of anxiety around that diagnosis as well. We've sort of shortened, we had a long questionnaire that we were asking patients at week 4 after diagnosis. And it was a very long-winded questionnaire, and not it was sort of self-completed by patients, and we didn't get much feedback from it. We've now shortened that question to 3 questions, which talks about quality of life post-diagnosis and levels of distress post-diagnosis. And I think patients have really valued clinicians asking those questions as well. Like I said, we're still sort of in the tweaking process, but just sort of when do we explore those questions? And Paul, you might help with that. Hannah, also you might help with that as well. So those are sort of the things that I wanted to just include in this discussion, really, from my own experience. And hopefully that will provoke discussion later with my colleagues and the audience.
Cool. Lovely, thanks, Sinead. Some really interesting issues there, some of which I've had to deal with in other contexts. You know, when do you assess people? When do you start intervening with people? I think those are really some... Will's disappeared now because he thinks I'm going to drone on. So I'll stop droning on and introduce the final speaker in this discussion, Will Lester. Will's kindly stepped out into a very strange environment room at a conference he's at to talk to us now. And Will is a haematology consultant in Birmingham, and he has got quite a few very important things. He's vice chair of the haematology.
Oh no, don't worry about that, mate. Don't worry about any of that.
Right, okay.
Yeah.
He works and provides clinical and haematology services to 2 hospitals by the look of it. So I'll hand you over to Will.
Cool, thank you very much, Paul. So about 17 years ago, I set up a thrombosis clinic because there was clearly an unmet need. These are the days of warfarin, and essentially everyone got put on warfarin. And most of the counselling that happened after diagnosis was about warfarin and about how you monitor warfarin and about the interactions. And then at 6 months, it was like a conveyor belt, and you just fall off the end of it. You just stop. And no one properly, I think, in many cases, addressed the actual queries and questions about the actual thrombotic event that had happened. And that was one of the intentions of setting this clinic up. And also to really identify people who shouldn't just stop at 6 months as well. I think things have moved on a lot, and I think most centres do have these thrombosis clinics. Ours runs at 3 months, so we see people 3 months after diagnosis. And my first question is generally, my opener is generally, how are the symptoms? You know, how's your leg? Is it improved? How's your breathing? You know, are you getting pains? And then we'll also move on to the second point, which is more of a sort of opener, really, where I'll say, you know, this thing that's happened to you, you know, it's pretty. It's pretty life-changing, and it's a massive shock to the system, both physically and mentally, because you can't separate mind and body. And at that stage, often there are tears, because I think sometimes people are naturally terrified. Not everybody, but a lot of people are, because especially if you're a young person who's been healthy, and then all of a sudden this thing has happened to you. And in 50% of cases, we don't even have an explanation, because 50% of cases are unprovoked. It completely destroys what I would call your health security, which is your sort of inner confidence that you're invincible. And just acknowledging that is really important, because often people maybe worry that their reaction to the event is abnormal, and it's about normalizing, saying, look, it's normal to feel like this. It's normal when you get a chest pain to think, oh my goodness, is this clot coming back? It's normal to feel breathless. It doesn't mean that the clot's not been treated appropriately. You know, and it's not uncommon to get leg pains. It doesn't mean, and it's about sort of meeting someone where they're at, I guess, and explaining that I guess addressing what people's individual fears are. I mean, the next thing we'd go on to would be the sort of journey, really. And obviously we've heard various stages of the journey. You know, the pre-diagnosis element is often quite protracted. It's long. Often healthcare professionals have perhaps been a bit dismissive. And I think sometimes people themselves feel frustrated with themselves for not pushing more. It's like, why did I take that? Well, I knew there was a problem. Why didn't I push more? And that's just, you know, to feel like that's it needs some sort of further time and discussions. And then when the diagnosis is made, it could be an ED environment, especially for pulmonary embolism. I suppose DVT is a bit more of an outpatient of experience, perhaps a bit more conveyor belt, but there's often the trauma of the inpatient admission and the communication issues. And then post-discharge, I think even though we've moved from warfarin to the DOACs, I think there's still quite a lot of focus on the actual mechanism of the medication and the safety aspects, which is really important, but we still have to address the issues about the actual thrombosis itself and what it means for future life. And I think in a nutshell, they're my main initial points.
Okay, thanks very much, Will. I think Will's been reading too many psychology textbooks, because that is the if you look at what are the key predictors of whether somebody's going to be traumatized, have post-traumatic syndrome or whatever, which I'm not saying people have, but something along those lines. It is sudden, unexpected, and life-threatening, and that fits. You experience an event that fits into those categories, and that clearly is an issue for, as Will has pointed out, particularly younger people. It's still, you have something that is completely unexpected. You may perceive it as life-threatening. And so it's hardly surprising that people have the reaction that they do. So thank you, Will. That was, we don't need a psychologist now. We've got you there doing it. Okay, so we're going to open up now, and there are no open questions. So if people have them, please put them in there. Save my stress. But I'm going to ask Hannah, because Hannah, when you were talking, Hannah, you talked about there was sort of bad communication, and then you had better communication subsequently. So could you give us some examples of what those bad and perhaps better communications were, just so it can make it a little bit more concrete?
Yeah, of course. Yeah. So just looking back at what Sinead and Will have said there. So Sinead saying about having a questionnaire, that's obviously a form of written communication where a patient will be able to write out how they're feeling. And then we're touching on the idea of at what point you should give that to a patient. At what point is a patient going to be able to write down how they feel emotionally? I think my experience in terms of mental well-being is that it wasn't mentioned. So that would be an example for me of bad communication. So it wasn't, and nobody ever said to me, you've been through something traumatic, how's that made you feel? And it took me a good 18 months, 2 years to sit back and think, actually, what I went through there was a lot. No wonder I'm feeling a bit overwhelmed. No wonder this has made me upset. No wonder I'm scared of things that feel irrational. I don't know. The example I often use is roller coasters. You go on a roller coaster and you hit your head. You ring 111 and say, I've hit my head and I'm on anticoagulants. They'll say go straight to A&E. But it was, I've always been an overthinker anyway. But then when it comes to things like that, you don't know who to ask these questions to. You don't know who to turn to. And I sometimes wonder if when I'd been diagnosed, if I'd have known those questions then, would I have maybe had the answers for them now, if that makes sense? So yeah, a mixture of maybe me liking to ask questions, but also not being told those things. Like Will said, you get told about how the drugs work, you get told about the warfarin and the DOACs and how they work in your body. But Joe said last week, and I'll never forget Joe saying this, but the anticoagulants don't make you feel better. They work inside your body, but they don't make you feel better. And that really hit me. I thought, actually, yeah, that's a really valid point. So anyway, good communication. I'm going off on a tangent. Good communication would probably be my GP afterwards. Audio.
Oh,
Can everyone hear me?
Hannah, I can hear Hannah. There's a message saying the audio is down, but I can certainly hear you, Hannah.
Shall I carry on, Paul?
Yeah, I can hear you.
Yeah. Okay, maybe a more local area. Yeah. Carry on, please, Hannah.
So good communication. My GP, after my diagnosis, I did have a phone call once the GP had received my letters from the hospital. And it was my GP ringing to ask how I was. And it probably wasn't from a mental health perspective, it was a physical health perspective. It wasn't just the blood clot I had go on at that time. I'd also, they'd found out I had some gynae issues going on at the same time. So I ended up having surgery and various different things as a knock-on effect. So the GP was probably ringing from a physical health point of view. But for me, that I know, I've worked in a GP surgery before. I know that letters get sent from the hospital back to the GP. I was touched that the GP had read that and actually thought, I'll ring them and see how they're doing. I appreciated that. And I think having that support from, because you look back, I'll ask my grandparents, and growing up, they'll have known their GP, they'll have been around in the community, everybody will have known the doctor. Whereas now you could probably see anybody at the practice. So I think even though I wasn't familiar with that one specific GP, I thought actually it's really kind of you to ring me and check in on how I'm feeling, and check in on how I'm doing. So yeah, kind of a mixture of good and bad. Yeah, I hope that kind of covers it, Paul.
Thank you very much.
All right.
Well, one of the issues that's come up is in information provision. And I think Jackie had some really good ideas on that, and others. I don't want to just point the finger at Jackie, but how do you work out what patients want to know? What are the sort of strategies for that?
Yeah, okay, so you have to listen to the patient to understand what they need to know, really, because you know what you've got to put forward to the patient. But you get a lot of ideas. If it's not from the patient, it could be with the person that's actually sitting there with them. You know, when you were doing a lot more, we actually do a lot of telephone consultations nowadays, whereas it used to be face-to-face. And you can get a lot of information just by the patient's behaviour, by their colleagues that are with them, either family, friends, etc. You can get a lot of information from that. You can find out about their lifestyle and have, you know, guesses of what they're going to need to know. I mean, a lot of patients, I think one of the things with the GPs, going back to something Hannah said about the GP contacting them, is we've had experiences where we have informed GP about patients having had a thrombotic event and that they require further medication, and then the patient gets to the receptionist saying, oh no, you're not on that medication, which is something the patient doesn't need. And it's okay if they are on warfarin, in that you can constantly feed that information to them, and there still are a small number of patients that are on warfarin, but it's the patients on the DOACs that just don't know where to go from there. So generally when we do the consultation, we do give them an email address to contact us. So we've got a generic email, so the patient can send us an email and say, I've got this problem, and we can help them deal with that problem. We tend to only hear from them once, sometimes never, but it's nice to have that opening for them. But there isn't really anyone there. The GP doesn't have a service generally for anticoagulation counselling. Very few surgeries do. So it's generally only at the hospital now. It's based at the hospital, and the service that provides now was, as Dr. Lester said, provided for warfarin patients and not for patients who are on DOACs. So perhaps we need to look at service provision going forward for those patients who are on DOACs.
Okay. Anybody else got any views on this particular issue? Sinead, are you still there?
Definitely still here. I think the communication, like Jackie said, is just patients just knowing there is someone to contact, especially once they're maybe discharged back to their GP. So we're here, we don't discharge them back till 3 months, but I know other services have to discharge back sooner. And so I think having a contact number, even if you can't speak to someone 24/7, even if it's within working hours, often provides comfort to patients as well. Or, you know, most patients quite like emails because they often think of the question at 10 o'clock at night and they can sort of fire it off to us, and we can come back to them the next morning with an answer, hopefully, just being able to say, oh, can I do this? Or do you think this is a good idea? Having that sounding board of an expert. And we're all in a fortunate position. If the question is particularly complex, we do have access to our consultants to often bounce that off of them as well and see what their opinion would be. So the direct access is to us as nurses, but we also have access to medical support as well. And sometimes that's quite a nice avenue of communication for patients and should definitely be something they deserve to have.
Yeah, I mean, I think it's interesting. I've been talking to a lot of people recently, and information, if they get information that they can take away, they just see that as so reassuring and vital that I think that is clearly there. Is there anything you'd like to add, Will, or shall we move on to another point?
I mean, information-wise, I mean, you sent some really good leaflets to me that come off the Thrombosis UK website. So I think that is a good place to start if you're thinking, yeah, I think we need to give more written information to patients at an early stage. So that's a bit quicker plug.
Yeah, thank you very much. Yes, leaflets are available. I'm going to take the opportunity as chair now, because I may have overstated something slightly when I talked about life-threatening clots, and there's a comment from, well, everyone can read it, so if you don't mind, I shall give the person's name, Keith Gomez, and he says, blood clots can be life-threatening, but it can be difficult to know which patients need to know that. We wouldn't be using that phrase for a small distal clot, and it's fairly obvious for a massive PE, but there's a spectrum in the middle. Now, yes, I may have overstated it. I'm not known for my lack of hyperbole, but I think one of the interesting things to me is when we've done surveys of, I mean, literally now surveys of a lot of people that have had blood clots, the levels of PTSD are identical in people that have had pulmonary embolism and have had something like a DVT. And if you talk to the people that have had DVT, yes, a DVT's presentation, clearly you're not having breathlessness and all those issues that can be very frightening and panicky. But as Hannah says, people go on to Dr. Google, they find that clots can move, and suddenly they get anxious about those sorts of issues. So I think sometimes the patient perspective is very different to the medical perspective, and that's partly why I think it's important to explore that when you are talking to people. I remember on a very different context talking about breast cancer surgery, and you know, one woman was horrified that she'd had the most small incision in her breast to look at a lump, you know, and another one was saying, thank God you've taken my whole breast, you've given me a lumpectomy, because they had different meanings, they were interpreted in different ways. So I think that that patient perspective is actually quite important, and it may not align with the sort of medical sort of perspective that I think most of us would have. I'll allow Keith to get back on that one, but I think you know that there is a difference between the two, and I think it's quite important. I'm just looking through to see if there's anything. Yeah, service provision for DOACs is crucial. Someone's saying, yes, we'll come back to that. Thank you, Claire. But this issue about DOACs versus warfarin, the sort of ongoing patient contact that you have when you have a warfarin clinic versus a sort of DOAC, I'm wondering what people feel are how do you manage that? If people are getting less and less follow-up, what do we do to sort of reduce anxiety, deal with issues when people aren't coming in on a regular basis? Sinead, you've got your hand up, so we'll go with you.
Yeah, I think that is the sort of allowing the door still to be open. So yeah, you have been discharged from the service in terms of you're not probably going to see us in clinic regularly. However, we are still sort of your provider of any expert advice that needs to happen as well. And we are fortunate here that we can still be able to offer that service. And like Jackie said, often it's some patients you sort of worry that you open up to so many patients this sort of email address or contact number and you're going to get inundated with calls. Often patients won't contact unless they really do need to, and with very valid points and questions. And we also learn a lot from those queries and questions, because often patients will come up with things that we haven't even thought about or we haven't ever come across ourselves as well. And so I think it is definitely, especially as the services definitely are undoubtedly changing sort of in the DOAC era, is to sort of remain open, basically, remain adamant that we are still kind of the experts in this care and we are the best people to answer those queries for those patients as well.
Yeah, thank you. Anybody? Jackie, have you got, Will's decided, I think Will's been sort of harassed in his room there at the moment. So anything anybody would like to add to that, or shall we go on to the next one? I think it's a really crucial issue, but keeping contact, maintaining that seems critical.
I think personally myself, I think it is a good idea to have that door open, but unfortunately there is a barrier in services in that they're being wound down an awful lot because they're not deemed to be required. And so to create a service, DOACs and warfarin should be treated equally. I feel they're anticoagulants, they have an equal respect, and you need to be able to give patients who have questions that service. But your service provision isn't necessarily identifying, because you haven't got, we're looking after so many patients, you haven't got a physical number of patients. That you'll find most warfarin anticoagulation clinics, they cling on to their numbers because that's what their bosses listen to, is the number of patients that they see, the number of patients that they're constantly seeing, because that number has dwindled significantly for a lot of anticoagulation clinics. The service isn't necessarily as well supported as it once was. And therefore you don't have...
The NHS is under financial pressure, are you?
Yes.
Yeah. Could you do that? Yeah, it's sad but true. Sorry, Hannah, you've got your hand up now.
That's okay. I thought it might be the easiest way. I don't want to interrupt.
Yeah, I like it. Yeah.
Just adding on to that, looking at my experience of how I was discharged. So I was seen by a haematologist after my diagnosis. They wanted to try and find out why I'd had the blood clot. And I stayed under him for a while, and then he referred me on to a bigger hospital locally. And I stayed under them for about 18 months, I think. So I was under haematology for a good 2 years after my diagnosis. But when it came to getting discharged, like we're saying, I wasn't given a leaflet to say, if you have any questions, contact us here. I was given, it was all telephone calls because this was through COVID at this point. And I was given a phone number, I think, for the reception, and it was to do with pregnancy. It was phone us if you're planning to have a baby. It wasn't phone us if you've got any questions about your medication or about your mental well-being or about symptoms or anything like that. It was almost safety netting me about contraception and pregnancy. So the way that it was left off for me with my experience with, all right, the hospital, I felt were good. I felt that they were good in treating me, obviously. The aftercare probably wasn't where it should be. When I hear these examples of questionnaires and phone numbers, or here's an email address that you can email at midnight and we'll email you back within a few days with these questions, I've definitely come across points since my diagnosis where I've thought, I wish I had someone to ask that question to. And my other experience with, say, ringing my GP and saying, can I have an appointment with a GP to go through some things? They'll just be like, I'm not really sure. And I've had times where I've been and sat with a GP and they've Googled it themselves. And I'm like, I could have done that. So I think, yeah, that communication is vital, and it probably differs around the country and around the NHS. But yeah, so that was kind of my experience of my being discharged. And I do just wonder if It might have been different, say, if I was on warfarin or if I was under a different trust.
I'm going to, this is fascinating. It could go on, but I'm going to raise one more issue, if you don't mind, because it's one of my pet things. I'm really not bringing this up because it is one of my pet issues, but there's quite a few people talking about it. And I'll tell you a very, very quick story. I gave a talk in Bangor many years ago, and I said one of the things that people really struggle with is when they're told you could have died. It's already been talked about. The hero doctor comes and saves the patient. And I said this is incredibly anxiety producing. And one doctor in the group stood up and said, but we've got to tell them. And another one said, no, we don't. And there was a massive sort of debate in front of me, which I just let continue. What do people feel about those sorts of messages? Should we be telling people these things? Yeah, go for it, Will.
You know what I think? I think people are massaging their own egos when they say that. The doctor gets more of that consultation. Whenever we have a consultation, in as many circumstances as possible, I want that person to feel better at the end than they did at the beginning. I know that's not always possible, but whenever possible, that should be the goal, I think. And I think doctors who say that are sometimes massaging their own egos. I'm blaming doctors. I don't know if other people do that too.
Also, yeah, to add, some patients want to hear sort of the hard facts and some people don't as well. And I suppose that's sort of the clinician having that experience to assess the situation really. You know, some people want to go into the details and some people really don't. So I think we can let ourselves off with we haven't got to have this huge checklist that we must tell them this, this and this. It's about responding to the patient's concerns that they bring to you as well and offering answers as much as possible around that as well. And as Dr. Lester said, sort of making them feel better about the situation rather than worse, and feeling well equipped to go off and manage medication and the condition sort of in the long term as well. So to be able to sort of, give them some answers.
Shut up, Sinead. That's it. That's perfect. Time's beating us. And actually, I think that's a brilliant ending because people have different information needs. Some people thrive on information. Some people, information is scary. So it's about asking the patient what they want to know, how much information they need to help them maximize their coping with whatever's going on. So I think that's a perfect ending, actually. So yes, I'm getting messages from Joe saying, stop, time's up. So I shall just say thank you to Hannah, Jackie, Will, Sinead. Really, I think now there's lots of questions coming up that I want to really get into and hone into. So I think this may be just the start of a discussion, but no, that was really interesting. Thank you very much. And I hereby close the session at this point. Is Joe there? Is she going to come and shout at us?
No, I am here, but thank you very much. It was really interesting. And I know this is a subject that we are going to continue discussing and bring into other areas to look at training and resources to help people think as well as provide and listen. So thank you very much, everybody. Thank you. Bye-bye.
Thanks, Joe.
Thank you.
Thank you.